So let me first get started. And my topic is going to be, where do we stand with MIGS? This is, of course, been a passion for me personally. It's been about, I will say, actually, 11 years since the first term of MIGS came up and popped into my head in terms of why we need a new kind of genre of procedures. And some things have changed and some things haven't changed. And so I'm going to basically provide this information as far as what I think things are at. These are my disclosures, and I do, of course, disclose a couple of things. Number one, I work with many different companies, and I realize that there are potential biases in our presentations. We want to be clear that we want to present proper evidence-based medicine, and we want to give you our opinion, which of course will be as bias-free as possible. My second disclosure is this picture right here, which is a picture of a red eye and a patient on multiple drops. And I have a clear bias. I'm against this type of picture. So that's my bias that's present here. So, of course, the traditional paradigm has involved numerous different pharmacotherapies that are available. We have laser trabeculoplasty, and we have surgical approaches. I think we probably agree that there's been a fairly large gap that exists in this paradigm between the relatively safer options of medications and lasers and then the more aggressive surgical options that are available. And this is where the whole interventional glaucoma era has come upon us. I think we're in it. We're in the middle of it. We're still kind of figuring it out. But I think the general concept that I think I've tried to sort of lay out here is that lower is better, earlier is better, safer is better, and we must address adherence appropriately. And we have to remember that the primary objective is not about IOP. It's not about a number. It's about quality of life. It's about the patient reported outcomes that we are important to assess. And it's not just the disease quality of life that we're trying to address. We're trying to address and address some of the serious issues we have with our medications and our surgical options that can affect quality of life. Let's remember over a patient's lifetime that the disease itself of glaucoma impacts the patient's quality of life very little until the very end stage of the disease. For so many years, it's an asymptomatic disease. It doesn't really impact the patient's quality of life. On the other hand, our medical therapies, our therapies that involve, administration of drops, for example, can lead to, years and years and years of potential issues that impact quality of life. So it's quite difficult, of course, for patients to kind of comprehend this problem where we're actually introducing issues that affect their quality of life. And so we must try to address these issues because we know that topical glaucoma therapy impacts vision-related quality of life in many ways, whether it's ocular surface related, whether it's visual issues, whether it's social issues. These are all problems. And when people have problems with treatment-related quality of life, it really provides a poor satisfaction. And again, like I said, compliance is impacted and social behavior is impacted as well. And we know that compliance and adherence are really critical when it comes to visual field stability. Any therapy, as good as it is, will only be as great if it actually is going into the eye or working, of course. And this is the data from SIGIS, just showing again, over time, patients become less compliant, less adherent. And as they become less adherent, the rate of progression and risk increases. And this is again supported by other data, again, monitored patients here, that when people are less adherent, they progress. So I think we all respect this and understand this problem here. We must address adherence in this new era of interventional glaucoma, addressing medications. We also know from numerous studies that really lower IOP is better, even for earlier cases. And we have, for example, anywhere from 10 to 20% risk reduction per millimeter mercury. So every millimeter mercury does count, especially if we're talking about patients in that quote-unquote normal range. We have data from AGIS, again, talking about the importance of keeping low pressures. We have data from the Canadian Glaucoma Study, even for early glaucoma, showing that patients who are lower, for example, 15 or so or lower, typically do better in the long run, even with early glaucoma as well. And also, this earlier treatment concept is important, that the effect of what we're providing the patient in preventing vision loss, if it's adopted early, will prevent that from occurring early in the patient's lifetime. And so earlier is better in these situations here. Now, traditional surgery is powerful. It's powerful. It's our most effective product we have to lower pressure. But of course, we also know that there are numerous issues with traditional filtering surgery, and they can be complicated. And although they're not common necessarily, these rare and serious complications, of course, impact our ability to use this as first-line or early therapy. The intensive follow-up is a problem. The refractive astigmatic changes, blood-related ocular discomfort, and as I said, the rare and serious potential early and long-term complications significantly impact the patient's quality of life. And this is, again, part of why interventional glaucoma is to move to a safer route. Now, the advent of MIGS, again, is really predicated on an Advent approach that's minimally traumatic, that is safe. That is safe, and that's really been the most important part of MIGS, as well as postoperative follow-up. Now, there are a lot of options in 2020, and I think I would say that it's really a confusing picture out there when you have all the different variety of options that exist in our hands in most parts of the world. And this creates, of course, some confusion in terms of, well, which device or which approach is the best approach. This is a paper from Ophthalmology Glaucoma, and you can see the variety of options available, whether it's traditional approaches or whether it's MIGS approaches, bleb forming or non-bleb forming, and then we have different options in terms of inflow, outflow, and trabecular or suprachoroidal. So it gets a bit confusing here, and we'll just briefly go through some of these different options. So this is one way to classify them based on the outflow target, whether they're conventional, whether they're superciliar or uvoscleral, or whether the approach goes more subconj. And again, there are different variety of approaches that exist and are present. So conventional surgery, of course, we have the trabeculectomies, we have tube shunts that have existed for many years. We know what they can do. We have studies on these now longer term. And then we have new ab-internal approaches that are designed, as well as ab-external microshunting as well, that are designed to potentially reduce some of the postoperative intensity. And these procedures, I will say, I think are a step up from traditional surgery in terms of the post-op recovery, in terms of the visual recovery, and as well as the ability to minimize hypotony and reduce some of the postoperative interventions that are required. But they still require a bleb. And that's why mitomycin, and that's why physiologic outflow, whether it's uvoscleral or trabecular outflow, is something to consider in terms of how can we improve things. And this is typically what we see with the traditional MIGS procedures that are now available. All of these procedures, whether they are cutting, trabeculotomy approaches, or whether they're cutting approaches like with blades, whether they're dilation approaches or stenting approaches, all are designed to bypass the trabecular meshwork and get aqueous into the conventional outflow system. This, of course, requires access to the collector system. This requires, of course, a patent collector system, which isn't necessarily always there, and also limitations that may exist in terms of downstream resistance that may be unknown and unclear. So they are safe, and I will say that I think that's one thing that we can be really comfortable with, that they're safe. But are they effective enough is what, of course, many people have asked in terms of these procedures and how they fit in the paradigm. This is where, of course, suprachoroidal flow in the gradient is well described and well known. These procedures are, again, something that perhaps can balance the safety efficacy. They're physiologic. They have a large absorptive space. And I know Paul's going to go through some more detail in terms of how they fit and the mechanisms that are at play with these procedures. So as we have this procedure, we have to think about MIGS here and think about safety and efficacy. And there's a balance between both these options here. Now, traditionally, there's been a tug of war. We give up safety for efficacy, or we give up efficacy for safety. And this has kind of been a tug of war. And our challenge is to try to see if we can try to get both potential here. And this is kind of the holy grail of glaucoma. Let's remember one more thing as well when we talk about MIGS differences here and different procedures, that it's not just about IOP. For the patient, it's about medication reduction. So when we look at studies, it's important to try to look and see medication, for example, and see what the medication reduction is and how it compares from one procedure to the next, because that, from a quality of life perspective, as mentioned earlier, is important. As we think about these procedures and options for glaucoma, let's divide them up between looking at risk on the x-axis and looking at IOP lowering on the y-axis. We know that medications and lasers, quite safe, but IOP lowering is limited. We know for tube shunts and trabeculectomies and mitomycin procedures that they are very, very effective, but they have higher risk, relatively speaking. Where we want to be is where the star is. That's where we want to be. We want to be really low risk and really effective. And I will say we still don't have that procedure yet. Trabecular MIGS kind of fit in that safer option, but not as effective as we'd like them to be. And subconj MIGS provides more efficacy, but still has potential side effects that can occur, again, with the mitomycin bleb. And this is where the question, the light bulb is in terms of, can we fit a procedure in this space that gives us more efficacy, but still maintains the safety of what we try to achieve with MIGS procedures. So what's next from MIGS? Well, it's about maximizing efficacy. I think that's where we have to be going. We have to think about how do we improve visualization, improve delivery systems, improve the ability to control wound healing. Drug elution and combination therapies are going to be interesting and useful. Imaging is important. And can we address the supraciliar space again as a viable target?